by activity. Tension type headache then is mild to moderate intensity. It's both sides. It's not necessarily aggravated by activity, and you don't have light or noise sensitivity with it. Then cervicogenic headache is caused by a disorder of the neck, and it's usually accompanied with neck pain, but not always, and neck range of movement is reduced in headache and migraine. So what I would say is the diagnosis of which headache gets very blurry, and like I'm just giving you an excerpt from the International Classification of Headache here on how to diagnose cervicogenic headache. So features that tend to distinguish headache, headache from migraine and tension type headache include side lock pain, provocation of typical headache by digital pressure on the neck muscles and by head movement, and posterior, like so from the back to the front, radiation of pain. However, while these may be features of cervicogenic headache, they are not unique to it, and they do not necessarily define causal relationships. Migrainous features such as nausea, vomiting, and photophonophobia, which is your light or noise sensitivity, may be present with cervicogenic headache, although to a generally lesser degree than in migraine, and may differentiate some cases from tension type headache. So I've included that quote because I just feel like it shows how the lines are blurred in like what is a cervicogenic headache and what is a migraine. And like it's really nice to see that, I suppose, in a medical textbook, that it, because we see it as in clinic, it's very much the case, but this shows you also in the medical textbook that it isn't, a straight, diagnosis of what you're suffering from. And I think a lot of people can probably relate to that their migraine doesn't always necessarily fit the textbook description of migraine. So keeping that in mind, it is proposed that rather than all headache types being separate entities, that cervicogenic headache and primary headaches are all on the same continuum. So this is due to the fact that there is a shared pathway causing all types of headache, which justifies the examination of the neck in all cases of headache. So basically, we know that in all headache types that there is sensitization of the brainstem, and that gives you a reason to look at the neck in all types, even if there is no neck pain present. And there's a little diagram here that kind of is showing that theory, so the convergence hypothesis it's called. And basically you have your different headache phases. So you have your pre-headache phase, headache phase, and post-headache phase. The pre-headache phase includes the premonitory, which is your like yawning symptoms, and then the aura, which is what comes before the headache. Then you can have this built-in tension where you get mild headache. And if you don't have the aura or the nausea, then that could be a tension type headache. And then as the symptoms build, then you can have your migrainous headache, which is with your nausea, light sensitivity, noise sensitivity. And then you have your post-headache phase, which, can last a little bit longer. And it's kind of that more into that like dull sort of headache without the nausea or the light or noise sensitivity. And you can see with all of them here that they have this trigeminal disinhibition, which I'm going to talk a little bit more about, the trigeminal pathway. Okay, so physiotherapy and migraine. The frequent co-occurrence of headache and neck pain is linked to the nerve supply of the head and neck in the dorsal horn of C1, C2, which is located in the trigeminal cervical complexes. This is a lot of big words, but basically what we're seeing here is that there is, let me see if I have a diagram here, I'll show you. So basically you have your head and this is the base of the skull here, and this is the upper three joints in your neck. The nerves from the upper three joints in the neck, instead of feeding down the pathway down like into the arms and the limbs, they feed back up into what we call the trigeminal nucleus. So basically their nerves feed back into the brainstem. And if you think of the brainstem as this whole area, there's this one specific area within the brainstem called the trigeminal nucleus. And that is the part that houses the nerves from the neck, but also then the nerves that go out to the head and the face. So the ophthalmicus, maxillaris, and mandibularis, which is the three nerves that supply the head and the face. And I'll just show you, if I can find it here, a little diagram which shows that quite nicely. I think this one's a little bit better. So here is your brainstem, and within the brainstem you have your trigeminal ganglion.
So Claire, we're still on that same slide.
Oh, okay. So let me see. Can I adjust that? I'm not sure. I'll just come back to this one. So basically, yeah, so this is supplying the nerves to the head and the face. So if you could imagine your head and face is divided up into three different sections, and each section is supplied by the different nerves, okay? So basically, there is more studies being done to investigate the relationship between the input from the neck and the headache now, okay? And this study by Carson and DeHerto in 2019 showed that an increase in noxious cervical spine afferents, which that means painful nerve pathways, has been shown to affect the excitability of the brainstem, and that brainstem sensitivity is believed to be a central part of the primary headache presentation. So basically, increase in signaling from the neck has been shown to affect the excitability of the brainstem, and a common feature of all headache types and is this sensitivity of the brainstem, and that we believe that is a part of why the neck is a central role in migraine. So basically, what is the brainstem? So the brainstem extends from the base of the brain to the first and second cervical segments. And it is in the area known as the trigeminal cervical complex that there is convergence of the nerves from the neck and the trigeminal nerve, okay? And the trigeminal nerve is, again, the branch that houses the three nerves that supply the head and the face. So then basically the co-occurrence of headache and neck pain can be explained by referred pain. Pain originating from the neck is perceived as originating from the head and vice versa. So basically, again, this is repeating the same thing, but basically headache during migraine is linked to the activation of the trigeminal vascular pathways, and animal studies have been able to show this referral of pain from the neck to the head, and then again from the head to the neck along this trigeminal vascular pathway. And then there's more recent human studies which have also shown this connection. So basically, headache has been stimulated by applying a stimulus. So they've injected a fluid irritant up into the upper three vertebrae in the neck. And then this has created a headache in the people that they did the study in. So that has been repeated like a number of times, and not just with the fluid irritant, but with other methods. And then they've also looked at anesthetic blocks. So there's been numerous studies again, but I'm just going to show you one here. And that is in 23 out of 32 patients with cervicogenic headache. So not migraine, but head pain was completely relieved after a diagnostic anesthetic block. So basically you're injecting into the nerve that sits right under the base of the skull, so where the base of the skull and the first vertebra meet. And if you inject that with anesthetic, that can take away your headache. And I've seen a number of patients who have had that done, and both patients with cervicogenic headache and migraine, and they've had between, I would say, 3 and 6 months resolution of their head pain. Then manual pressure to the upper neck segments has been shown to reproduce your familiar head pain in those with migraine and tension type headache. So it's not just, people with neck pain and with restricted neck range of movement that you can reproduce head pain in. It's people with migraine as well. Okay. So other studies then have looked at the neck in terms of what's going on with the neck in migraine patients, and you will see a dysfunction of the neck muscles. So they look specifically at the deep neck flexors, which is kind of like the core muscles of the neck, and they will be weak and they'll lack endurance. So they'll not be able to hold a contraction for a certain amount of time. And then they also look at the joints and posture, and there's been numerous studies, and that has been found, I suppose. And you can see then studies with trigger points. So trigger points is when there is tension in certain bands of muscles, and then restricted neck movement and stress on the upper joints have all been related to different types of headaches. But no studies have been able to be done to prove a causal relationship. So basically that a trigger point in a certain muscle causes a certain headache, or dysfunction of these muscles causes the headache. That hasn't been proven, and it would be very difficult to prove because, as we know, with head pain, it's multifactorial, and it would be very hard to prove a causal relationship. So while we're seeing that this is a feature of a lot of clients with migraine, tension type headache, cervicogenic headache, it's not necessarily what causes your symptoms. Okay. So then looking at intervention, so like what impact, doing anything to the neck has then on headache and migraine. So there's been different animal and human studies looking at this relationship. And again, anesthetic blocks applied to the greater occipital nerve through the C1-2 facet joints, the first two joints in the neck, have been proven to be effective in reducing headache. And there's numerous studies to show that. Then there has been a review study on random control trials. So that's trials that will comparing manual therapy against other forms of therapy. So like standard care, which is GP management with medication, etc. But this study looked at specifically a lot of different studies that examined massage, physio, relaxation, and manipulation. And they concluded that they might be equally effective as propranolol and topiramate in the prophylactic management of migraine. So that means as a preventative measure in migraine. But most of the trials were of poor quality, so there needs to be a lot more studies done to prove what this review was suggesting. Studies have shown association of tension type headache with neck impairment, range of movement, neck flexor endurance, and greater head forward posture. So we know that people with their heads slightly forward off their trunk, with weak neck flexor muscles, with reduced range of movement in their neck, that they have a larger association of tension type headache than people without them features. A comparison of usual care by a GP to neck physiotherapy in tension type headache sufferers showed an 87% compared to a 27% reduction in headache. So basically the people that were randomized to the neck physiotherapy, they reduced their headache. There was an 87% reduction in headache as opposed to 27% who were managed by the GP alone. And the reduction there was over 50%. So it was quite a significant change to the amount of headaches that people were getting. So the manual therapy group received mobilization to the neck, strengthening of their neck flexor muscles, and then posture correction through exercise, advice, education. So there is a limited number of studies that have looked at the role of physiotherapy in migraine, and there needs to be a lot more work done. And this is probably why it's less well known, is because it hasn't been studied extensively in the physiotherapy population. So a lot more work needs to be done to bring physiotherapy into mainstream practice for migraine management. But it is happening, and it's starting to happen more and more. Okay, so now what I'm going to do is I'm going to talk about the Watson method, which is the method that I've been trained in. So I'll talk to you a little bit about the method and then my experience with the method. So the Watson method was developed by Dr. Dean Watson, a physiotherapist in Adelaide, which is in South Australia. He has been specialising in headache for over 40 years and has received his PhD for his research in headache management. So his technique looks at the neck as a source of symptoms, but also as a means to affect the brainstem activity. So again, we're talking about that common feature in migraine, tension type headache, cervicogenic headache, vestibular migraine, of the brainstem being more active or more sensitive than in the non-migrainous or non-headache population. So examination focuses on the first 3 joints in the neck, and what the examiner is doing when they look at the first 3 joints in the neck is we're looking for segmental mobility and alignment, headache reproduction and resolution through the application of sustained digital pressure. The upper neck is suspected to be playing a role if a presenting headache is resolved or if typical headache is reproduced and resolved. So you're looking for the symptoms that you've experienced all the time. Can we reproduce them symptoms? And not only can we reproduce them, but can we get rid of them with like a mild to moderate pressure on the upper 3 vertebrae in the neck. Okay, so if the neck is suspected as playing a role, a treatment program is initiated. Treatment is generally consisting of 6 sessions over about a 4-week period. So it's not an ongoing, generally it's not ongoing, like you're looking for discharge in around the 4 to 6 week mark. There's no manipulation involved, although there has been some studies that have looked at manipulation in migraine, and they have also had a positive effect. But this is not a manipulation technique, it's sustained pressure. Treatment then focuses on improving the alignment and segmental mobility through sustained manual pressure from the therapist, and then home exercises by the headache sufferer. So everyone will be given a specific exercise in the early stages, and you'll be given advice on like posture and exercise management. And that's a big part of physiotherapy. So you're rarely going to get physiotherapy where you're not educated or given exercises. And that's an extremely important component of the Watson method, even though there is a really large focus on the manual side of things. So like what we do with our hands, but then the person who's suffering from headache also is given the tools then to help themselves as much as possible. And that's basically the aim of physiotherapy, is to get you like independent in your own management. And that's no different than with the Watson technique. Okay, so reduction in the referred pathway of pain is achieved through the reproduction and resolution of the client's familiar head pain. So what you're trying to do with each session is you're trying to desensitize that pathway of tension in the neck, causing referral into the head. Okay, so every intervention is assessed for effect, and if no improvements are seen within a few sessions, treatment will be ceased. Each individual responds differently, and treatment is tailored to the individual and the presenting symptoms. So if we look at the science to back this up, it's still very much emerging science, really. But there's been 3 published studies, peer-reviewed, and Watson and Drummond, 2012, they examined 34 primary headache sufferers and were able to reproduce familiar head pain in 85% of sufferers. And this suggests a role for referred pain in primary headache. And then in 2014, they did a study which assessed the excitability of the brainstem during and after treatment and found a reduction in brainstem activity and head pain referral with the sustained pressure techniques. So basically they were able to show that we can reproduce your familiar headache, and then not only that, but that sustained pressure could also affect the brainstem. So we know basically from these studies that by application of pressure to the upper part of the neck, that can affect the brainstem, and that we think that is what's causing a referral then into the head and face, causing headache and migraine. Okay, then another study, Davidson et al. 2018, assessed 101 migraineurs who received 5 sessions of the Watson technique over a 3 to 6 week period. They then assessed outcomes at 4 weeks, 3, 6, and 12 months post the treatment. So really brilliant study in terms of what they were trying to achieve, but unfortunately only 40 people completed all the data. But the results did show significant reductions in intensity, duration, severity, and medication use. But unfortunately, with such small numbers, you can't extrapolate that to everyone. So more studies are needed to back this research up, basically. And there is a lot more research going on. So all over the world, I think people are starting to study the Watson method and its effects. So basically my experience with the Watson method, so back, I'd say it's 5, maybe 6 years ago, I completed 2 3-day courses in the Watson technique up in Sydney with Dr. Dean Watson. I then worked in a specialised headache and migraine clinic in Melbourne city centre under the direct supervision of Roger O'Toole. So basically I worked in a clinic that only seen headache and migraine sufferers, and there was a lot of supervision, a lot of use of the Watson technique. And having seen numerous headache and migraine sufferers now over the years, I've seen the transformative effects of the Watson technique. So what I'm going to do is just go through a case study of someone that I've seen recently with headache and migraine. So it was a 67-year-old lady with a 50-year history of headache and migraine. So she had bilateral head pain, but she had nausea, blurred vision. She would get headaches once a month if she was doing really well, but mostly she was getting 1 to 2 a week. Medication, she was on amitriptyline, Excedrin, magnesium, and vitamin D, so supplements as well as prescribed medication. And there was a strong family history, which is very common with migraine for a number of members of the family to have suffer from headache and migraine. So what I did then was I would have examined her neck. So I'm just going to show you here if I can, so you can see. So basically what I have here is a model of the head and the neck. So here is the base of the skull, and then when I come down from the base of the skull, I'm going directly onto the C2 spinous process. So the first vertebrae in the spine you can't actually feel with your hands. That's because it's tucked right under here. So when I come down from the skull, I'm coming straight on to the first vertebrae, okay? And then I can feel down onto the to the third. So this is the second spinous process, the third spinous process, and this is the area where I'm examining. So when I examined my lady, case study A, when I came down, I would examine where her spinous process was sitting. And generally in most people, it's deviated to one side. So it's slightly rotated off to the side. It's not that there's anything out of place. It's literally just tightness in muscle. So we have a little muscle sitting over here. Okay, and that goes from the first to the second vertebrae. And that muscle will be under a little bit of spasm. And it's not just migraine sufferers that have this spasm in their neck, but it causes a slight rotation of that second vertebrae. Okay, so I'm looking to see like where that is, and it often corresponds to your symptoms. So if you're right-sided, you know, all the time, right-sided symptoms, oftentimes this rotation will be to the right, but not always. Okay, so when I examined my lady, she was deviated to the left. So her spinous process was rotated slightly to the left. And then when I came down here and pressed to the side, it was really stiff on the left, but moved quite nicely on the right. And then I would have examined these joints here. So you have facet joints. They're like, I always explain it, they're like two dinner plates. So it's vertebrae number 2 sitting on top of number 3, and they're like two dinner plates. And when you turn your head, they should slide and glide nice and easy. But what happens if there's any bit of rotation? They'll get blocked slightly here. Okay, and that will correspond. So you're kind of building up a picture as you examine the neck. So you're thinking, okay, if this is deviated left, there's going to probably be some tightness here, maybe some stress on the joint on the other side because they're working all together. So I'm examining that, and then I'm going to look for pressure on C3 that corresponds to that. So the pressure on C3, if it's deviated to the left, will be more likely on the left, as we find here with this lady. Okay, so then what I do is examine, is that feature there? So does she have that feature with deviation off to one side? And then if she has, we see, can we correct it? So by applying the sustained pressure to this joint or to this joint, can we release that spasm basically? And can we correct the deviation? Okay, so that's the first part of the assessment. The second part of the assessment then is seeing, can we reproduce your familiar head pain? So I'll come in here along the OC1, it's called. So basically where the skull and the first vertebrae meet. So you can't directly apply pressure because I can't feel it exactly, but you're sitting over that joint basically with my hands, and you're coming along the arch of C1 here. Okay, and what I'm doing there is it's quite gentle. It's like you're literally just applying a little bit of pressure, and that will cause in a headache and migraine sufferers reproduction of your familiar head pain. So you know, if it causes pain in your like right jaw, but you only get pain in your left jaw, it doesn't count. We're looking for the exact pain that you get. So can we reproduce it? And then if I hold the pressure there, will the head pain go away completely? And that's what both them components have to be there for us to think that the Watson method will work. Okay, so in this lady, she was deviated to the left. She was stiff on a sideways pressure to the left, her facet joint on the left, the two dinner plates were stiff, and the pressure on her C3 was left, and the left side only reproduced familiar head pain. So when we come over here to the right side, there was no reproduction and referral of her head pain. So it's very specific, and it's, you know, specific to your pain. Okay, so what we did then was a treatment of 5 sessions over 5 weeks. And she probably would have done 2 sessions a week for 2 weeks, and then it is extended out a little bit after that. So we use the sustained pressure to correct that deviation, and then the client was given retraction-based exercises, so basically a chin tuck exercise, and then they'll be told to avoid head forward postures and head down. So your phone is a big one, like that head down posture, but a lot of people would know this anyway, that they need to avoid these positions. And then desensitization of the referral pathway through reproduction and referral of typical headache was done with then mild pressures just under the joint. So after seeing this lady, she had no migraine from the start of treatment. She had what she would describe a headache rather than migraine once, which required medication, and had a couple of episodes that were alleviated with the chin tuck exercise. So she was discharged after 5 visits. And that is how you want the treatment to go. And it's best case scenario for her and for me, you know, like it's a brilliant outcome, especially given, so she had a 50-year history of migraine, and it was still really effective for her. There is other, you know, scenarios where it takes a little bit longer. So like I remember a lady that I treated in Australia was also a physiotherapist, and she was a physiotherapist in a hospital, and she worked with respiratory patients. So she had always had a stethoscope around her neck and shoulders. And it was when she seen me, she was at the point where the stethoscope was too heavy and it caused her pain. And it's extremely light instrument. And she had a, you know, 10, 20-year history. I can't remember exactly. That's why I didn't include her in the case study. But she had a really long history of headache and migraine. And we did the Watson technique with her, and it reduced her headaches like really significantly. So she would have been having something like an 8 out of 10 pain daily, which, you know, got worse as the day went on. She would have had a lot of anxiety, and she would have been very unfit. And so while we reduced her headache significantly with the Watson technique, it didn't resolve her symptoms completely, and she never corrected. So her tightness on her neck never corrected completely. So then with her, I started doing Pilates, and she ended up coming to me for, you know, probably 18 months of Pilates, like group session. But by at the start, she couldn't hold, like, as I was saying, she couldn't hold the weight of the stethoscope. And by the end, she was doing full push-ups. She was going traveling for 3 months, no migraine, no headache. So while this patient that I've given you here is like a textbook sort of example, but as we know with pain, and specifically head pain, it's so complex and multifactorial that you cannot say the technique will work the exact same for every person. So it's extremely effective, I would say, but it works differently depending on each case. Okay. So the role of exercise then, to move on from the Watson method. So they're like funny, when I started with the Watson journey, I didn't realize there was other physiotherapists specializing in headache and migraine that don't do the Watson technique. So there is other physiotherapists that specialize in different approaches, more looking at exercise, different modes of manual therapy, and they have some studies and really nice studies as well. And then there's a general studies of how exercise plays a role in migraine management, and then how like self-management can play a role as well. So that's just what I'm going to speak about now. So there's been studies shown that active physical treatment, including exercises, have promising effects on the reduction of head pain in those with neck pain. So people that have head pain but also have neck pain, they have been studied, and basically exercise as part of their physio treatment have shown really promising effects on reduction of head pain. There has been association of low levels of physical activity and high frequency of migraine has been reported in several large population studies. So that's not to say again that the low levels of physical activity cause migraine. As most of you will know, that basically it's harder to probably exercise while having a migrainous episode. But that is something that is clear, so that people that suffer from migraines will often have lower level of physical activity than non-headache population. A review of studies on exercise and primary headache showed that exercise resulted in fewer headache days and reduced intensity of symptoms. So what that means is people who did aerobic exercise or resistant exercise had fewer headache days, and the intensity of their headache was reduced in comparison to sufferers that didn't exercise, basically. So there is also moderate quality evidence indicating that depression, anxiety, poor sleep, stress, medication overuse, and poor self-efficacy, which is confidence in your own ability to affect your problem, for managing headaches are potential prognostic factors for poor prognosis. So basically, if you've got high levels of stress, using a lot of medication, poor sleep, anxiety, you're going to be have less favorable outcomes from preventative treatment in chronic headache. So the more elements of these you have, the less likely you are you're going to not benefit as strongly from treatment in chronic headache. And then studies that examine self-management compared to usual care being GP and medication. This study showed that people who had self-management techniques, so which had components of mindfulness, education, cognitive behavioral therapy, relaxation, and group interventions, they had a superior effect than those who just received usual care alone. Then there has been studies done on the effects of yoga in the treatment of tension type headaches and migraine, and it showed a statistically significant effect on headache intensity, frequency and duration in tension type headache, but not in migraine. So again, lines are blurred as to the diagnosis around tension type headache and migraine, and also there is a lack of really strong evidence in this area, but there is, again, studies showing the beneficial effects of yoga. There just needs to be better studies, basically. Then there has been studies done on high intensity type exercise versus continuous moderate sort of aerobic exercise. And so there was a number of, I think it was about 16 studies all in all, and a review comparing them could show that there was a superior effect with high intensity type exercise on migraine episodes and cerebrovascular health. But I don't think there was the same outcome with tension type headache. So examination of aerobic exercise and resistance training in migraine and tension type headache indicates that both are effective in reducing frequency and severity of headache. But larger studies are required to examine which is the best exercise intensity for treating specific headache. So we cannot say that resistance training is more beneficial for tension type headaches based on the amount of evidence that there is. So basically, we know that exercise is going to have a positive effect on migraine like days. So basically it can reduce days, it can reduce intensity, can reduce medication use, but we cannot say what amount of exercise is required, when to do your exercise, what type of exercise. There needs to be a lot more studies done to ascertain basically the most effective type of exercise. And there is some evidence to say as well that, you know, intense exercise can cause migraines, and people have type of migraine that is exercise induced. So again, you cannot extrapolate these findings to every individual. There's a lot of variability within migraine diagnosis, but then there's a lot of variability in lifestyle, you know, patterns, and also, you know, the type of exercise. So while it seems like, why isn't there better evidence, it's not as easy to examine the effectiveness of exercise as it is to examine the effectiveness of medication. It's a little bit more straight cut. You take this tablet, you don't take that tablet, whereas exercise gets blurry. You know, how do you measure the exercise? How do you measure the intensity of the exercise? And I think that's something to keep in mind when we're thinking about the quality of the evidence of physiotherapy. Again, you cannot just prescribe a pill and examine the effectiveness of it. Physio is very case dependent, so your interaction with each client will be different, and that's really important to think about when you're looking at the effectiveness of physiotherapy in the management of migraine, because they will also be taking medication, and you can't eliminate the effects of them, so it is a more complex area to examine, and I would like to use that as an excuse for why the studies aren't as good as they should be, but it's also probably because there has just not been enough research done. But I would say there is a lot more research being done at the moment. There's some like nice studies coming up that will be published over the next couple of years, and hopefully that will be really effective at getting physio treatment into mainstream population. But what I would say is don't wait on the evidence, because it's very hard to get good evidence out there. And first of all, and secondly, it's very hard to get it into the public domain. Like, how do we translate evidence into practice and get GPs and other, you know, healthcare providers to know that physio can have such a positive role. And that's probably a big reason why I'm grateful to be able to talk about it today, is because there's not that many opportunities as physios to show how effective it can be. So basically that concludes the topic. But if you want to find out more about me, I have a website, Instagram, Facebook. I have a YouTube channel, and there's a few videos there that are specific to headache and migraine. And so that is like relaxation, so yoga and Pilates techniques that you can use and see, you know, do they have an effect? You know, you can build it into a self-management program that you have at home, and that can be a really effective way of not just managing your symptoms, but preventing the onset. So if you notice that you're getting stressed or tense, there's really effective ways to manage that. Yoga being one, and then the Pilates is kind of a little bit more around strength and building up the strength and endurance in these neck